Welcome back to the deep dive. This is where we take that dense, critical source material, the stuff you really need to know, and just break it down into something you can actually remember and use.
Yeah, and today we are getting into a big one. We're opening up Davidson's medicine, and we're doing a full forensic examination of acute stroke.
A really big one.
Yeah.
And our mission today is critical, isn't it? Because stroke, it's not just some common emergency. It's the third most common cause of disability in the world.
It is. So what we're going to do is navigate everything. The classifications, the clinical presentations, which can be really subtle, the diagnostic roadmap where time is everything, and of course the emergency management.
And for you, the learner, this whole deep dive, it's designed to give you that mental scaffolding, the key concepts, the anchors. Everything you need to really master this.
I think we should just jump straight in.
Let's do it. Let's start with the highest yield concept of all, the big picture anchor.
Mm-hmm.
So what actually defines a stroke, and what are the main flavors we're dealing with here?
Okay, so a stroke has two defining characteristics. One, it has to be of sudden onset.
Sudden, not gradual.
Not over weeks, no,
Yeah.
Sudden. And two, it has to cause focal cerebral dysfunction. So a specific problem in a specific part of the brain, that's what separates it from, say, a faint or a metabolic issue, which affects the whole brain globally.
Okay, sudden and focal.
Exactly. And when you look at how it happens, the mechanism, it really splits into two main camps.
The block versus the bleed.
The block versus the bleed, you've got it. About 80%, so the vast majority, are caused by cerebral ischemia.
So that's the block. An infarct.
Yep, an infarct. A blockage that leads to tissue death because it's starved of oxygen. The other 20% are hemorrhagic strokes, a bleed.
And that breaks down even further.
It does. You've got intracerebral hemorrhage, which is a bleed directly into the brain tissue itself. That's about 15% of all strokes.
Okay.
And then you have subarachnoid hemorrhage, which is a bleed into the space around the brain. That's the other 5%.
And you mentioned a really rare one as well.
Yeah, we have to remember the non-arterial causes, which can be really confusing. Things like central venous thrombosis or CVT, but that's less than 1%. So really understanding that fundamental 80-20 split between a block and a bleed, that is the cornerstone of everything we're going to talk about today.
Okay, so let's unpack this. Before we talk about what goes catastrophically wrong, we have to get a handle on the brain's normal plumbing system, right? The cerebral circulation.
That's absolutely the right place to start. The brain is supplied by two paired highway system.
Two byways.
Two highways. First, you have the anterior circulation. This supplies most of the cerebrum, and it's all fed by the two internal carotid arteries, the ICAs.
Right.
Once the ICA gets into the skull, it splits. It bifurcates into the anterior cerebral artery, the ACA, and the middle cerebral artery, the MCA.
And the MCA territory, that's a huge one, right? Probably the most clinically significant.
It's massive. It's the one that's most frequently affected in a stroke. The MCA supplies the whole lateral surface of the hemisphere. So that includes the motor and sensory areas for the face and the arm.
Oh, okay.
The frontal eye fields, and critically in the dominant hemisphere, the language areas, Broca's and Wernicke's.
So that's why an MCA stroke gives you that classic devastating combination of, one-sided weakness, sensory loss, and difficulty with speech.
Exactly, the classic triad. The ACA, on the other hand, it supplies the medial part of the hemisphere, the bit that sort of dangles in the middle.
And that controls
The legs and feet. So a pure ACA stroke often causes this really prominent leg-only weakness, which is a big clue.
Okay, so that's the anterior system. Then we pivot to the back, the posterior circulation.
Exactly. This system starts with the two vertebral arteries. They travel up the neck, and then they merge together to form one single large artery, the basilar artery.
And that one supplies some really critical structures.
Absolutely vital structures. The brainstem, the cerebellum, the pons, everything involved in consciousness, breathing, coordination.
In a stroke, there is catastrophic.
It can be. The basilar artery then finishes its journey by splitting again into the two posterior cerebral arteries, the PCAs.
And the PCA territory.
That supplies the back of the cerebrum, most importantly, the occipital lobes.
Vision.
So PCA strokes almost always present with some kind of visual field deficit.
It seems like the brain has this crucial bit of redundancy built in. Before we move on, let's just highlight that safeguard, the Circle of Willis, as the emergency bypass road. Why is that so important?
It is the brain's ultimate insurance policy, well, provided it's complete.
Yeah.
The Circle of Willis is this ring of arteries at the base of the brain.
A ring. Oh,
Yeah, and it's formed by communicating arteries that connect everything. They connect the left and right sides, and crucially, they connect the anterior system, the carotids, with the posterior system, the basilar.
So if one of those main highways gets blocked,
If a major feeding artery, say your internal carotid, gets blocked, a complete circle of Willis allows blood to be rerouted from all the other arteries. It can just bypass the blockage,
and that can prevent a stroke entirely.
or at least minimize it. But, and this is a really critical clinical insight, anatomical variations are incredibly common.
So not everyone has this perfect bypass road.
Not at all. Many people have an incomplete circle of Willis. Maybe a communicating artery is tiny or it's missing altogether. And when that bypass road isn't there, a blockage in a single artery suddenly becomes a much, much bigger problem.
That context is huge. It explains why two people with the exact same blockage can have totally different outcomes.
Completely different. It's all about the collateral supply.
Okay, and just briefly, what about the return plumbing? The venous system.
Right. So the venous blood drains back through a series of big channels called dural venous sinuses. They run over the brain's surface and eventually empty into the jugular veins in the neck.
Lower pressure system.
Much lower pressure. But if it gets blocked in something called cerebral venous thrombosis, it causes this massive back pressure. You get raised intracranial pressure and sometimes even a secondary bleed. It's a very different beast to an arterial stroke.
So now that we have the territories, let's look at the different breakdowns.
Yeah.
Let's classify these strokes by their severity and the size of the lesion.
Yes. We have to anchor this to the fact that arterial infarcts, the 85%, are clinically categorized. We use the Oxfordshire classification, which gives us a really useful shorthand for how the patient is going to do.
Okay, so let's start with the big one, the anterior carotid circulation, which is about 65% of all infarcts.
All right, so within that, you have three main types. Number one is the total anterior circulation stroke, or TACS.
Total. So this sounds like the worst one.
It is.
Okay.
Think of this as the most devastating, massive stroke. It accounts for about 15% of infarcts. To have a TACS, you need two of the three main clinical features.
Sure.
Significant motor or sensory deficit, so hemiparesis, higher cerebral dysfunction like dysphagia or visuospatial neglect, and a hemianopia, a visual field defect.
Wow. So it takes out everything.
It suggests a huge area of cortex has been starved of blood, usually because the main MCA stem or the ICA itself is blocked. The prognosis here is generally poor.
Okay, so that's TACS, the big one. What's next?
Next is the partial anterior circulation stroke, or PACS. This is a smaller, incomplete cortical stroke. It's much more common, about 30% of infarcts.
So the patient might just have, say, weakness and a visual field problem, but their speech is fine.
Exactly. Or they might have all three, but in a much less severe form. The prognosis is generally much better than a TACS.
And the third one in this group.
The third is the lacunar stroke, or LACS, and this one is anatomically and clinically very distinct.
How so?
These are tiny, deep infarcts. They're caused by the blockage of these little, tiny perforating arteries called the lenticulostriate arteries.
Okay, small and deep. So what does that look like clinically?
Classically, it results in a pure motor or a pure sensory deficit. But, and this is the key, they lack any cortical features.
No dysphagia, no visual problems.
None, because the damage is deep, in the white matter tracts, not in the cortex itself. And they are very strongly associated with small vessel disease from long-standing hypertension and diabetes.
That structure really helps. TACS is big and bad, TACS is moderate, and LACS is small and deep and points to a different underlying cause.
Exactly. That thought process is vital. And then you just have the last one, the posterior circulation stroke, or POCS. That's the other 20%.
And these are the ones affecting the brainstem, cerebellum.
Yep. Brainstem, cerebellum, occipital lobes. So they present with things like ataxia, vertigo, diplopia, visual field loss. Their severity is all over the map, from a tiny occipital stroke to a fatal basilar artery occlusion.
Right. That covers the ischemic side. And on the hemorrhagic side?
That 15% is split. You've got intracerebral hemorrhage, or ICH, which is 10%. That's a bleed into the brain tissue. And Subarachnoid hemorrhage, SAH, which is 5%, that's a bleed around the brain, usually from a ruptured aneurysm.
And they're treated totally differently, which is why imaging is so urgent.
Totally differently. It's the first and most important decision you have to make.
Let's do our first self-check.
Okay, check-in question. Which of those stroke classifications, TAXI-S, PASI-S, LACS, or POCS, is most strongly associated with long-standing, uncontrolled hypertension? And why does that syndrome typically lack symptoms like dysphagia or visual field deficits?
We'll give you a moment to think about that.
The answer is lacunar stroke, LACS. They're linked to hypertension because high blood pressure damages those tiny, deep perforating vessels, and they lack cortical features because the damage happens deep below the cortex, affecting only the white matter tracts carrying motor and sensory information, not the gray matter that handles language or vision. If you didn't quite connect LACS with small vessel disease and the lack of cortical symptoms, maybe just pause here and rewind that last section.
Okay, here's where it gets really interesting. We're moving from anatomy to the clinical reality. A patient comes in, the clock is ticking, and we have to do this rapid neurological detective work. So how do we spot a stroke versus one of its many mimics?
You know, the source material really emphasizes this idea of a sudden, focal, and typically negative deficit.
Negative symptoms, what does that mean?
That distinction, negative versus positive, is probably the most important one you can make at the bedside. A typical stroke symptom is negative. It's a loss of function.
Loss of movement, loss of feeling.
Exactly. Loss of movement, loss of sensation, loss of vision. And it happens suddenly, within minutes. If the symptoms are positive, things like pins and needles that spread or march across the body, or visual hallucinations, or rhythmic jerking.
So adding something, not taking something away.
Right. If you see positive symptoms, you have to think about a stroke mimic. Things like a focal seizure or a complicated migraine, especially before you start giving clot-busting drugs.
Okay, so let's detail those typical presenting problems. The loss of function. Negative symptoms. We'll start with the most obvious one. Weakness.
Weakness, or hemiparesis, is the most common presentation. A lesion in the cortex or deep white matter causes these upper motor neuron signs on the opposite side of the body. But the pattern of the weakness gives us huge clues.
So it's not just that one side is weak, it's how it's weak.
Exactly. If the stroke is in the MCA territory, which we said controls the face and arm, you'll see severe face and arm weakness. But the leg might be relatively spared.
Right.
If the lesion is in the ACA territory, you'll see that isolated, pronounced leg-only weakness we talked about.
And what if everything is weak equally?
If the face, arm, and leg are all equally weak, but there's no sensory loss, that points really strongly towards a classic lacunar stroke deep in the internal capsule.
And the most frightening pattern.
If you see quadriparesis weakness in all four limbs, you have to immediately suspect a devastating stroke in the brainstem, where all those motor pathways are bundled together.
Next up, speech disturbance. This is always confusing. Let's really clearly define dysphagia versus dysarthria.
We can anchor this distinction with one question. Is the problem with language processing or language articulation?
Processing versus articulation.
Dysphagia is the processing problem. It's a cortical issue, usually in the dominant hemisphere, the left side for most people, and it breaks down into two types.
Recepting and expressive.
Right. Receptive dysphagia, or Wernicke's, is difficulty understanding. The person can speak fluently, but it's meaningless. It's often called a word salad.
And expressive.
Expressive dysphagia, or Broca's, is difficulty producing grammatical speech. They understand you perfectly, but their speech is halting, effortful, telegraphic.
And dysarthria.
Dysarthria is the articulation problem. Slurred speech. The language center is totally fine, but the motor control for the tie, lips, and palate is damaged, and that can be caused by a stroke almost anywhere. Cortex, cerebellum, brainstem.
Let's move to visual deficits. What are the specific presentations that scream stroke?
There are really three main ones. The first is sudden transient monocular blindness, which has the fancy name amaurosis fugax.
A curtain coming down over one eye.
That's exactly how patients describe it. A curtain coming down, lasting for a few minutes, then lifting. It's caused by a temporary blockage in the ophthalmic artery, usually from a little clot that shot up from the carotid artery in the neck.
And even though it's temporary, it's a huge warning sign.
It's a TIA, a transient ischemic attack. It warrants an immediate aggressive stroke workup.
Okay, what's the second visual sign?
The second, and probably most common in an established stroke, is a contralateral hemianopia.
Losing half the visual field.
Yep. Damage to the visual pathway, usually in the occipital lobe from a PCA stroke, causes loss of vision in half of the visual field on the side opposite the stroke.
And the third?
The third is gaze preference. An acute stroke in the frontal eye fields, that's MCA territory, makes the patient's eyes look toward the lesion.
So a right-sided stroke makes them look to the right.
Exactly. It's a really important localizing sign.
Now, when the stroke affects the non-dominant cortex, usually the right side, the symptoms get, well, a bit weird. Things like visuospatial dysfunction.
They're subtle but incredibly disabling. We see sensory or visual neglect. The patient acts as if the entire left side of their world just doesn't exist.
So they'll only eat food from the right side of their plate.
Shave only the right side of their face, or even deny that their paralyzed left arm belongs to them. We also see apraxia, the inability to do complex, learned movements, like using a key even though they have the motor strength to do it. These are classic non-dominant hemisphere signs.
What are the anchors that should make us immediately think a lesion is in the posterior circulation, the brainstem or cerebellum?
Okay, two big ones. If the patient presents with ataxia, a sudden loss of balance and coordination that isn't just due to weakness, you have to think cerebellum.
Right.
And second, any signs that point to damage to the cranial nerve nuclei in the brainstem. Things like diplopia, double vision, vertigo, or severe dysarthria. Finding those essentially rules out a simple cortical stroke and points you to the back of the brain.
Okay, let's talk about the alarms, atypical symptoms.
Yeah.
The signs that suggest a bleed or a massive lesion.
Headache is the #1 alarm. I mean, some people with ischemic strokes get a headache, but it's rarely severe. If a patient presents with that cardinal sign of a subarachnoid hemorrhage, a sudden, severe thunderclap headache that hits maximum intensity in seconds.
The worst headache of their life.
The worst. Or if the headache is severe and they're vomiting, you have to suspect a bleed. Similarly, if the patient presents comatose, that points to a devastating event. Either a massive intracerebral bleed, huge brain swelling, or a stroke right in the brainstem.
This assessment needs to be standardized, which brings us to the NIH stroke scale, NIHSS, the severity thermometer. This is fundamental, right? Because getting treatment often depends on this score.
It is. The NIHSS is just a quick, formal 11-item neurological exam that we use to measure how severe a stroke is. It's quantifiable, it's reproducible, and it lets everyone from the paramedics to the ER to the neurologist speak the same language about the patient.
And the score goes from 0 to 42.
Yep. 0 is a normal exam, 42 is the most severe, devastating stroke imaginable.
Let's just quickly break down the key domains, because the structure of the exam is just as important as the score.
It is. It systematically checks function. It starts with consciousness, asking simple questions, then it moves to gaze and visual fields, then cranial nerves, specifically facial palsy.
And the core of it is motor function.
That's the core. Items 5 and 6, it's the motor drift test. You have the patient hold their arms out for 10 seconds and their legs up for 5 seconds, and you're looking for any drift downwards. Scoring goes from 0, no drift, to 4, no movement at all.
And after motor?
Then it finishes with cerebellar function or ataxia, and then sensory, language, dysarthria, and importantly, inattention or neglect.
And you mentioned there are some critical rules for scoring.
2 big ones. First, you score what you see. You don't coach the patient, and you don't attribute a deficit to an old problem unless you're absolutely sure. Second, the severity tiers really guide treatment. A score of 0 to 5 is mild, 5 to 15 is moderate, and those are often the patients who are good candidates for thrombolysis. And anything over 16 is severe, and you're thinking about thrombectomy.
But a key limitation, you said, is that the NIHSS doesn't measure all strokes equally well.
Exactly. The scale is heavily weighted towards those big cortical deficits, weakness, aphasia, neglect. It often underestimates the severity of posterior circulation strokes. A patient could have debilitating vertigo and ataxia, but still have a relatively low NIHSS score. So clinical judgment always has to come first.
Okay, time for our next check-in.
Check-in question. Beyond quadriparesis, which is obviously a brainstem sign, lists 3 specific components of the NIHSS that would allow you to differentiate a total anterior circulation stroke, TACS, from a lacunar stroke, LACS.
Take a second to think through the scale.
Okay, so TCS involves the cortex. So you'd be looking for positive abnormal scores on item 3, visual fields for a hemianopia, item 9, language for aphasia, and item 11, inattention neglect.
Right. All cortical signs.
All cortical signs. A LECS, on the other hand, which is deep white matter damage, should score 0 on all 3 of those. It would only score points on motor drift and maybe sensation.
A really important distinction.
It is. If you struggle to link those specific NIHSS items to the cortical syndromes, it's worth just quickly reviewing that classification section again.
So the clock is ticking. We've established a focal deficit. We now enter this rapid diagnostic phase. And the ultimate goal, as we said, is telling a block from a bleed.
This is the critical decision point, and the speed of your investigation dictates whether or not you can treat the patient effectively. This brings us to brain imaging. CT versus MRI, the speed versus detail trade-off.
Let's start with the undisputed champion of speed, the non-contrast CT.
The non-contrast CT is the immediate workhorse. It's fast, it's everywhere, and it is exquisitely sensitive for acute intracranial hemorrhage. Blood on a CT scan shows up bright white. It's impossible to miss.
So the main purpose of that first scan is to look for blood.
That's it. The primary purpose of the acute CT is to exclude a bleed. If the patient has clear stroke symptoms and the CT shows no blood, we proceed with the diagnosis of an ischemic stroke.
But here's the key point for learners. The CT can be normal in an early ischemic stroke, can it?
It often is. CT is actually pretty insensitive to the early changes of infarction. In the first few hours, the CT might look completely normal. We might see some very subtle signs, like a dense MCA sign, which is the clot itself, but you don't need to see a dark area infarct to make the diagnosis.
So a normal CT in someone with stroke symptoms is a green light for treatment.
It's a green light for thrombolysis, assuming they're in the time window. Clinical presentation trumps the initial CT finding.
Okay, so CT is the rapid exclusion tool. If we need more detail or have more time, we turn to MRI.
Right. MRI gives you vastly superior anatomical detail, especially for tricky areas like the brainstem and cerebellum. But the crucial sequence we use is diffusion-weighted MRI, or DWI.
What does that show?
It detects the earliest cellular change of ischemia, which is called cytotoxic edema. This causes water molecules to get trapped inside dying cells, and they can't move around freely. DWI detects this restriction of water movement, and the ischemic tissue lights up like a light bulb on the scan.
And it shows up almost immediately.
Within minutes of the stroke onset, it makes MRI the gold standard for definitively identifying acute ischemia.
Okay, but it takes longer.
Yeah.
So what are the non-negotiable reasons to rush someone to imaging immediately? This is our immediate imaging indication anchor.
These are the absolute red flags. If you see any of these, the patient goes straight to the scanner. 1, the patient is on anticoagulants like warfarin. You have to rule out a bleed.
It makes sense.
2, the patient is a potential candidate for reperfusion therapy thrombolysis or thrombectomy.
Right.
Time is brain, so you can't wait.
Right.
3, the patient has a deteriorating conscious level. This suggests a big swelling lesion that might need surgery. And 4, you suspect a cerebellar hematoma or infarct. These can swell and cause obstructive hydrocephalus, which is a neurosurgical emergency.
So once the CT has ruled out a bleed, we shift to finding the cause of the blockage with vascular imaging.
Yes, now we have to find the culprit vessel. We use things like carotid ultrasound, but more and more now we use CT angiography, or CTA.
And what's the purpose of that?
2 main reasons. First, to look for carotid stenosis in the neck. If there's a significant narrowing, that patient may need surgery later to prevent another stroke.
And the second reason?
Second, and most critically in the acute phase, the CTA identifies a major vessel occlusion, an LVO, a clot in the ICA or the proximal MCA. Seeing that is the ticket to getting mechanical thrombectomy.
Okay. And since up to 20% of these strokes come from the heart, we have to do cardiac investigations.
Absolutely. You have to hunt for the source. A standard 12-lead ECG is mandatory to look for atrial fibrillation, or AF.
But AF can come and go.
It can. It can be paroxysmal. So if the stroke looks embolic but the ECG is normal, that patient needs prolonged monitoring, like a Holter monitor, to try and catch it.
And what does an echocardiogram add?
The echo looks for structural problems. It can see vegetations from endocarditis or a clot sitting in the heart after a big heart attack. But crucially, it looks for a patent foramen oval, or PFO.
A hole in the heart.
A small hole between the right and left atria. Normally, a clot from your leg would go to your lungs. But with a PFO, that clot can cross from the right to the left side of the heart, bypass the lungs completely, and go straight to the brain.
A paradoxical embolus.
Exactly. And identifying that changes your management plan.
And finally, we do blood tests to uncover the systemic risk factors.
Right. We do the routine stuff, but the targeted tests are for planning secondary prevention. A fasting glucose to find undiagnosed diabetes. A lipid panel to guide statin therapy.
And in the acute setting?
In the acute setting, the most important are the clotting factors, PT, AKTT, platelets. If you have a bleed, you need to know if you need to reverse any anticoagulants. And if you're planning thrombolysis, you need to know the baseline bleeding risk.
So let's sum this up. The key insight on diagnostics is this. The immediate priority of imaging is simply to exclude a hemorrhage. A normal CT scan in a patient with acute stroke symptoms is not a reason to relax. It is a critical step on the treatment pathway that requires you to trust your clinical judgment.
Okay, what does this all mean? We have a probable ischemic stroke, we've ruled out a bleed on CT, we are now in the golden hours, and management is all about minimizing brain damage.
It is, and to understand the time pressure, we have to anchor our management in the pathophysiology, the ischemic cascade and the penumbra.
The penumbra, this is a huge concept.
It is. When a vessel blocks, you can think of the affected brain tissue as two distinct zones. In the middle, you have the core infarct. This is tissue where the blood flow drops so low for so long that it's already dead. It's irreversibly gone.
Nothing can save the core.
Nothing. But surrounding this dead core is the penumbra. This is tissue that's alive, but it's not working. It's stunned because of the reduced blood flow.
So this is the tissue we're trying to save. This is the therapeutic target. The entire acute management strategy, thrombolysis, thrombectomy, it's all designed to restore blood flow to the penumbra and save it from becoming part of the core infarct.
But saving it has a risk, right? The hemorrhagic transformation?
It does. The ischemic process makes the blood vessels in that area very fragile. So if you restore flow too aggressively, especially with clot-busting drugs, those fragile vessels can leak, and you get a secondary bleed into the infarct, which is why patient selection is so important.
Which brings us directly to reperfusion therapy. The time window is everything. Let's start with intravenous thrombolysis. Alteplase.
Alteplase, or TPA, is a fibrinolytic. It's a clot-busting drug. We know from major trials that it improves functional recovery if it's given within 4.5 hours of when the symptoms started.
4.5 hours? That's a tight window.
It's very tight. And the clinical reality is that the benefit of the drug goes down with every single minute of delay, while the risk of causing a bleed goes up. So we have to be incredibly strict with the inclusion and exclusion criteria.
So things like recent surgery or being on anticoagulants.
All absolute contraindications. You have to select the patient very carefully.
But what if the clot is just too big for the drug to dissolve?
Then we move to the mechanical approach. Mechanical thrombectomy, clot retrieval. This is where an endovascular specialist goes in with a catheter, usually through the femoral artery in the groin, threads it all the way up to the brain, and physically pulls the clot out with a device.
And this is for the large vessel occlusions, the LVOs.
It's profoundly effective for LVOs in the anterior circulation, the ICA, the proximal MCA. Now, initially, the time window for this was 6 hours.
That's changed, hasn't it?
It's changed dramatically. Landmark trials, DAWN and Diffuse 3, used advanced imaging to look at the penumbra. And what they found is that if the imaging shows there's still a large amount of salvageable tissue, you can extend the window for thrombectomy up to 24 hours.
Wow. From 6 to 24.
It's a total game changer. We're now treating, based on brain physiology, how much penumbra is left, not just an arbitrary clock.
This is a really complex area, so let's tackle the apparent contradiction in blood pressure management in acute stroke. The rules are completely different depending on the type of stroke.
They are completely opposite, and it's based on pathophysiology. Let's start with intracerebral hemorrhage, ICH, a bleed.
Right.
Here, we reduce the BP aggressively and early. We target a systolic blood pressure generally below 140. The high pressure is what's driving the bleed and making the hematoma expand, so you have to bring it down.
Okay, so for a bleed, lower the pressure. What about an acute ischemic stroke? The block.
Here, we do the opposite. We practice permissive hypertension. We deliberately avoid lowering the blood pressure abruptly.
Why? That seems so counterintuitive.
Because the brain tissue downstream from that clot has lost its ability to auto-regulate its blood flow. It is completely dependent on a high systemic pressure to push blood through collateral channels around the clot to perfuse the penumbra.
So if you drop the pressure, you could kill the penumbra.
You can turn the salvageable penumbra into a dead core infarct. So we only lower the BP if it's crazy high, like over 220 systolic, or if there's another major medical problem going on.
But there's an exception to that rule.
There is. If the patient received thrombolysis, if they got alteplase, then we do keep their systolic BP below 180 for the first 24 hours.
And that's not to help the stroke.
No. That's purely to reduce the risk of the drug causing a secondary intracranial hemorrhage. It's a real tightrope walk.
What about immediate drug management with aspirin and antiplatelets?
Okay, for a moderate to major ischemic stroke, you start aspirin, 300 milligrams daily, as soon as you've ruled out a bleed on the CT.
Unless.
Unless they got thrombolysis. If they got TPA, you have to wait 24 hours, get a follow-up scan to make sure there's no bleed, and then you can start the aspirin.
And for a minor stroke or a TIA?
The data is now very strong for using dual antiplatelet therapy. So, aspirin plus clopidogrel for the first few weeks. That combination significantly reduces the very high risk of having another stroke in those first few days.
All of these amazing interventions are useless without meticulous supportive care and the stroke unit.
This is absolutely foundational. Rapid admission to a dedicated, specialized stroke unit is paramount. The data is unequivocal. It reduces mortality and disability.
And the numbers are pretty staggering.
They are. The source material highlights that for every 1,000 patients you treat in a specialized unit, an extra 50 will avoid death or long-term disability compared to being on a general ward. It's a huge effect.
And what are the immediate priorities on that unit?
First is a swallow assessment. Dysphagia, or difficulty swallowing, is incredibly common. You have to do a bedside swallow test before they eat or drink anything to prevent aspiration pneumonia, which is a major cause of early death.
And second?
Second is monitoring for deterioration. If the patient gets worse, it could be the infarct extending or brain swelling. But you have to first quickly rule out the simple, reversible causes that can mimic a worsening stroke: hypoxia, sepsis, seizures, or low blood sugar.
And what's the role for surgical intervention in this acute phase?
Surgery is really reserved for life-threatening swelling. For a huge MCA stroke in a younger patient, a decompressive hemicraniectomy, where you remove a big piece of the skull to let the brain swell out, can be life-saving.
Life-saving, but with significant disability.
Often, yes. And for large cerebellar bleeds or infarcts that block the flow of spinal fluid and cause hydrocephalus, they may need immediate ventricular drainage to relieve the pressure.
Okay, let's do a check-in on that complex management.
Check-in question. You have a patient with an acute ischemic stroke, NIHSS of 10, who is on warfarin. Their CT scan is negative for hemorrhage, but their INR is 3.5, so very high. What acute reperfusion therapy are they immediately ineligible for, and what specific imaging finding must you rely on to determine if they might still be eligible for the other reperfusion therapy?
This is a tricky one. Take a moment.
Okay. So with an INR of 3.5, they are immediately ineligible for intravenous thrombolysis, alteplase. The bleeding risk is way too high.
Right.
However, they might still be eligible for mechanical thrombectomy. But to be eligible, the CTA scan must confirm a large vessel occlusion, LVO. Without an LVO, thrombectomy is not an option. This is a really important real-world distinction.
Okay, so connecting this to the bigger picture, we're moving out of that life-saving acute phase and into the marathon of prevention and recovery.
That's right. And this is so important because the risk of having another stroke is incredibly high. It's 5 to 10% in the first week and about 15% over the first year. So secondary prevention is absolutely paramount.
Let's run through the aggressive secondary prevention strategies, the things that really alter vascular risk long-term.
Number one, without a doubt, is blood pressure management. And this is where the rule flips. In the acute phase, we allowed permissive hypertension. Now, for secondary prevention, we need aggressive reduction.
What's the target?
We aim for a target of less than 130/70. Studies show that reducing BP, even in people with normal blood pressure, significantly reduces the risk of another stroke.
And what about cholesterol?
Lipid lowering is essential. We use high-intensity statins, atorvastatin, rosuvastatin, to aggressively lower the LDL cholesterol. And this isn't just about future plaque. Statins also have anti-inflammatory effects that stabilize the existing plaques and make them less likely to rupture.
And then there's the big one, lifestyle modification.
It's non-negotiable. Smoking cessation is probably the single most impactful thing a person can do. Then you have dietary changes, lowering salt, fat, alcohol, and increasing exercise and losing weight.
Now, the major intervention for cardioembolic strokes is anticoagulation, usually for patients with atrial fibrillation.
Correct. For these patients, lifelong oral anticoagulation is essential. The trials show that in high-risk patients with AF, anticoagulation halves the risk of stroke. It might take the risk from 4% per year down to 2% per year.
And that benefit outweighs the bleeding risk.
It vastly outweighs the small increase in major bleeding risk. And today, we generally prefer the DOACs over warfarin because they're easier to manage and have a lower risk of intracranial hemorrhage.
Okay, let's talk about when an intervention is needed in the neck itself, carotid surgery. Who is a candidate for a carotid endarterectomy?
So this is for symptomatic patients, people who have had a TIA or a stroke that we can clearly link to their carotid artery and who have a significant narrowing or stenosis of more than 50% in that artery.
And the benefit is biggest for the worst blockages.
Exactly. The benefit is maximized for severe stenosis from 70 to 99%. But, and this is the high yield part, the surgery has to be done quickly, preferably within the first 2 weeks after the event. If you wait, the benefit drops off dramatically.
Let's move to rehabilitation. This is where the brain literally tries to rewire itself. What are the 3 phases of recovery?
Phase 1 is early recovery. This happens in the first few days. It's a rapid but limited improvement that's mostly due to the brain swelling going down and the penumbra waking up.
Okay.
Phase 2 is the big one, neuroplasticity, the rewiring. This is where new brain areas actually start to take over the jobs of the damaged areas. This is most active in the first few months, but can go on for a year or more.
And this is driven by therapy.
It is driven by intensive, repetitive practice, physical therapy, occupational therapy, speech therapy. But there's a key caveat. Therapy starts after 24 hours. Very early mobilization within that first day has actually been shown to be potentially harmful.
And the 3rd phase?
Phase 3 is adaptive recovery. This is learning to live with whatever disability remains. Using mobility aids, adapting the home, finding new strategies to maximize quality of life.
What are some of the common rehabilitation barriers that can slow this whole process down?
Well, you have the medical barriers, post-stroke pneumonia, delirium, but the psychological barriers are huge and often overlooked. Profound apathy, especially after a non-dominant stroke, severe fatigue, and post-stroke depression. These things just crush a patient's motivation to participate in rehab.
And what are the milestones you look for?
We look for measurable progress. Things like achieving independent sitting balance, then progressing to standing balance, and then the big one, being able to walk 10 meters. Those are the standard goals that help us measure recovery.
Let's pause for one more check-in on this transition from acute to chronic management. Check-in question. For a patient with an acute ischemic stroke who received 5E thrombolysis, describe the immediate 24-hour goal for their systolic blood pressure and the long-term blood pressure target for secondary prevention, and explain why they are so different.
Take a moment to think about the rationale here.
Okay, the immediate 24-hour goal is to keep their systolic BP below 180 mmHg, and the rationale is purely to reduce the risk of the thrombolytic drug causing a hemorrhagic transformation.
Right. And the long-term target is aggressive lowering, aiming for less than 130 over 70 mmHg. And the rationale there is to reduce the very high risk of having a recurrent stroke. Acute phase is about preventing treatment complications. Long-term phase is about systematic risk reduction. If that's still a bit hazy, it's really worth reviewing that section on acute BP management.
Okay, now let's dive deeper into 2 specific syndromes that represent the extremes of vascular pathology: subarachnoid hemorrhage and cerebral venous thrombosis.
Let's start with subarachnoid hemorrhage, SAH, the thunderclap. This is a catastrophic bleed into the subarachnoid space, the fluid-filled space that surrounds the brain.
And what's the main cause? Why does it happen and where it happens?
About 85% of the time, it's due to a ruptured saccular or berry aneurysm. These are these little pathological blisters that form at the bifurcations of the arteries in the circle of Willis, right where the pressure and turbulence are highest.
So places like the anterior communicating artery.
Exactly. The ACOM, the PCOM, the MCA bifurcation. And the risk factors are what you'd expect: smoking, hypertension, and a family history.
The clinical presentation is unmistakable, isn't it?
It's defined by one cardinal symptom: a sudden, excruciating thunderclap headache. The pain hits maximum intensity instantly, within seconds. Patients will say it felt like being hit in the head with a baseball bat.
And that's often associated with vomiting, neck stiffness.
Vomiting, photophobia, and neck stiffness, though the stiffness might take a few hours to develop as the blood irritates the meninges.
Are there any high-yield focal signs that can point you to a specific aneurysm location even before you get a scan?
Yes, there's one classic one. An expanding aneurysm on the posterior communicating artery, the PCOA, can press on the third cranial nerve. This leads to a painful third nerve palsy, so a droopy eyelid and a big dilated pupil that doesn't react to light. If you see that, it's a huge red flag.
So let's walk through the time-sensitive investigations, the SAH protocol.
The protocol is very strict because missing an SAH can be fatal. Step 1 is an emergency non-contrast CT scan. It's highly sensitive for acute blood.
And what if the CT is negative, but you're still suspicious?
If the CT is negative but the story is classic, you must do a lumbar puncture, LP. And critically, you have to do it about 12 hours after the symptom onset.
Why the 12-hour wait?
Because you're not just looking for red blood cells, you're looking for xanthochromia. This is a yellow discoloration of the spinal fluid that's caused by the breakdown of red blood cells into bilirubin, and that process takes time. If you do the LP too early, you can get a false negative.
And if the SAH is confirmed?
Then you need to find the source. You get a CT angiogram or a formal angiogram to find the ruptured aneurysm so you can treat it.
And the management has two goals.
Two big goals: prevent rebleeding and prevent vasospasm. You have to secure the aneurysm, usually with intravascular coiling within 72 hours, and to prevent the arteries from spasming down days later, which causes a secondary stroke, we give every patient the calcium channel blocker nimodipine.
Okay, let's shift gears to the drainage system. Cerebral venous thrombosis, CVT. The sinus blockade, much rarer.
Much rarer. This is a clot in the cerebral veins or venous sinuses. And because the veins drain the brain, a blockage causes the blood to back up, leading to severe congestion and a massive increase in intracranial pressure.
And what predisposes people to this?
It's often linked to hypercoagulable states, systemic causes like pregnancy, the oral contraceptive pill, inherited clotting disorders, or cancer, or local causes like a bad sinus infection or meningitis that spreads to the veins.
And how does that increased pressure present?
The symptoms often evolve over days or weeks, so it's less sudden than an arterial stroke. You get features of raised ICP, a persistent headache, vomiting, visual problems. You can also get seizures and focal deficits.
And the diagnosis is made with?
MR venography, MRV, or CT venography. The scan will literally show the filling defect, the absence of blood flow in the blocked sinus.
Okay, now for the crucial counterintuitive management. Why do we give anticoagulants even if the blockage has already caused a bleed?
This is the most challenging concept. Yes, a venous blockage can cause a venous hemorrhage, but the root of the problem is the blockage. The clot is what's causing the pressure to rise and making the veins leak.
So you have to treat the clot.
You have to treat the underlying problem. The goal is to prevent the clot from getting bigger and to help the body's own systems break it down. So even if there's some venous hemorrhage on the scan, the standard of care is immediate anticoagulation, first with heparin, then long-term with warfarin or a DOAC. The benefit of stopping the clotting process far outweighs the risk of worsening the venous bleed. So, to synthesize everything we've covered, stroke requires immediate assessment. That assessment is driven by the need for a rapid CT scan to rule out a hemorrhage.
Right. Block or bleed.
Block or bleed. That decision then allows for time-sensitive reperfusion for ischemic strokes thrombolysis within 4.5 hours and thrombectomy, now up to 24 hours, for large vessel occlusions if the imaging shows a salvageable penumbra.
And then survival transitions to the long game.
Exactly. Aggressive secondary prevention type, BP control, statins, anticoagulation for AF. And then the final recovery is all down to comprehensive multidisciplinary rehabilitation that's driven by the principles of neuroplasticity.
And that leads us to our final provocative thought for you to think about. We talked a lot about neuroplasticity, the brain's slow, often spontaneous process of rewiring itself. We noted that therapy starts after 24 hours. Given how fragile and important the penumbra is in those early days, how might future technologies, things like transcranial magnetic stimulation or vagal nerve stimulators, how might they fundamentally change what recovery means by actively manipulating that rewiring process in the first week?
Could we transform recovery from a passive process into an actively managed, accelerated one?
Could we give the brain a biological kickstart immediately after the acute phase is over and bypass months of slow, intensive physical therapy?
That's the edge of future stroke care.
Thank you for joining us on this essential deep dive into stroke medicine. Until next time, keep digging.